Yeah, so this study focused mostly on idecabtagene vicleucel, which was the first FDA-approved BCMA-directed CAR T-cell therapy for patients who had received 4 more lines of therapy. This was back in March of 2021. And we've seen some toxicities, particularly severe toxicities like grade 3 or higher CRS and ICANS occurred in about 5 and 3% of patients. But what we wanted to really analyze in this study is, what factors predispose a patient to experience these severe toxicities, and then what factors may associate with durable responses. So really the main purpose of our study was to identify and analyze pre-treatment characteristics and key biomarkers that associated with toxicity and durable responses in patients receiving commercial idecabtagene vicleucel and consented to a biospecimen protocol at our institution. So this was essentially a retrospective sample study. We had about 108 patients that were included in this study. As I mentioned, all of them received standard of care idecabtagene vicleucel. In this protocol, we analyzed serum cytokines at different time points within a patient's treatment course, utilizing a type of immunoassay called alloimmunoassay. We isolated peripheral blood mononuclear cells, and that's to capture peak CAR T expansion at serial time points. And then we also looked at bone marrow biopsies that were done before lymphodepletion or CAR T-cell therapy, and that's to analyze immune cell subsets of part of the bone marrow environment that may predict for these toxicity and durable responses. So in this study, as I mentioned, we had about 108 patients. We found that about a third of the patients had very high-risk features, particularly patients with extramedullary disease, those who have pentaclast refractoriness, high plasma cell burden, and high-risk cytogenetics. We also identified that patients who experience or were more likely to experience severe CRS, so like grade 2 or higher CRS these patients receive a higher median CAR T-cell dose. And in those who are more likely to experience neurotoxicity, these patients had higher plasma cell burden, more advanced disease, triple class refractoriness, and a higher baseline inflammatory state as evidenced by clinical biomarkers like ferritin and C-reactive protein. We also found some cytokine associations with CRS as well as ICANS, and we identified certain immune subsets that also associated with CAR expansion as well as durable response. Particularly, we identified monocytic myeloid-derived suppressor cells, reduced CAR expansion. We found that peak cytokines associated with peak CAR expansion and ultimately a durable response. And also durable responders were more likely to have higher CD4-CD8 ratios, as well as stem central memory CD8 positive T cells in their pre-CAR T bone marrow biopsy. And we did also identify that in patients who have high disease burden, they're more likely to experience T cell exhaustion, or markers of T cell exhaustion were found in the bone marrow biopsy, essentially leading to impaired activation, proliferation, increased expression of inhibitory immune receptors favoring tumor immune tolerance. I think the significance here is that, we were able to identify that, patients who have a high disease burden and a high inflammatory state, they're able to identify an association with toxicity and durable response, as well as an association with, cytokines, immune subsets with CAR expansion and durability of responses in patients receiving this product. But really what's important about this study is that hopefully provides some insight into potential avenues for toxicity mitigation, as well as therapeutic optimization in patients who are deemed to be high risk for experiencing either a non-durable response or increased risk for toxicities.
Okay,
and this is not just restricted to ID-cell, it could be for any novel immunotherapies.